So basically my title is The Revolution of NGS in Lung Cancer for a Better Targeted Therapy. And I just have put this image of revolution because for me, revolution means three topics which speak for NGS. The first one is the crowd, meaning that now NGS represent many things together, many targets. The second thing is the complexity, because even if we think we understand, it's still quite a complex topic. And the last thing, of course, is the cause and the understanding, right? We have been learning and understanding why a revolution and why the NGS. And I try to cover all of these topics with you today. This is a set of slides we prepared. It's important for me to say with Noémie Réguard, you all know very well. She allowed me to present them for another meeting, and it's a joint and common work that I'd like to present today that I completed a little bit. You'll see at the end with some politics and policy slides. So this is my disclosure. So just to start, we have to remember that we have been doing unselected treatments for decades, and this is the John Schiller papers that all students need to know, but showing that basically when you don't personalize chemotherapy, first of all, the outcome is kind of poor, less than a year, but more than that, that whatever you do without biomarkers looks like to be pretty equivalent. A platinum-based chemo is a platinum-based chemo. So basically everything starting from here, from Tony Mock and from IPAS, thinking that broad molecular testing today will allow for better informed treatment decision-making, starting from EGFR, and of course, going abroad at the time being. I like also this paper 10 years after John Schiller of Fogelstein, trying to understand the cancer pathway, right? Trying to divide it to 12 pathways. I would say, oncogenic phenotype, what confers a selective growth advantage to cancer cells. And when you think what Fogelstein had published in Science in 2013, it's really maps today what we can do, first of all, with targeted therapy, with PARP inhibitors, with immunotherapy. So I think these 12 pathways, I invite you to go back to this wonderful paper, are really summarizing the advances we've been facing in the field of dedicated and targeted customized treatment. And of course, the pie, which will be shown so many times, moving from my old days of oncology, adeno, squamous, and others, to this wonderful sets of potential oncogenes and targets with a lot of actionable targets, probably 10 to 12 today in adenocarcinoma, and a list of oncogenes in squamous cell carcinoma, which unfortunately for the majority of them, if not all, are still not actionable per se. What we start to discuss today, and that the topic of my talk, is CGP, which means comprehensive genomic profiling, which is the way now we got to move to identify these actionable targets, allowing the detection of multiple types of molecular alteration, looking of course at mutation, but also looking beyond, remember our colleagues, at DNA mismatch repair, maybe at TMB in some of these entities. And of course, with this now, I would say, comprehensive need of understanding that CGP has to enlarge over time and maybe also encompass an RNA sequencing in order to make sure that complex modification of the structural genomic information can be looked at, particularly fusions and chromosomal rearrangements. Knowing all that, of course, we now have data. Remember Mark Chris already 5 years ago, but this is another very nice paper of Al-Ahmadi showing that this retrospective analysis using large institutional database in the US in patients with advanced disease, showing that if you use NGS, it was foundation one, or if you don't, you will of course identify patients, targets, treat them accordingly, and I would say dramatically improve the survival of patients if you sequence. Of course, now it's part, I wouldn't say of a molecular tumor board per se. For me, it's part of the thoracic tumor board, something to discuss maybe together. But basically, we need now this molecular data to have a correct discussion at the thoracic tumor board, right? About adjuvant treatment, about advanced disease. So it's now part also of the job of the discussion with the surgeon and the radio-oncologist. We need to know this molecular data at the thoracic tumor board. What material to be tested? So now we know that the quality of tissue sample is key. It's not only key for RNA, it's key also for DNA in order to perform right biomarker analysis. And there are some critical steps that makes not all centers equivalent. We have quality control assessment now of everything we do in order to make sure that this molecular profiling will reveal the oncogenes which are needed. And of course, it has to be controlled, but it has also to be fast, because remember, this data shows showing that if you have no driver or a driver, if you have a driver and you don't identify it, you fell down on the left scenario where patients progress and die very fast. While if you can identify the driver, you might even save the life of some patients, particularly with aggressive disease like ALK disease can be. And again, speaking about the RNA level, remember it has to be fast, but it has also to be accurate. MET is probably the best example where some diseases look at MET amplifications. In lung cancer, we like to look at exon 14 skipping mutations and sometimes at fusion with rare partners. And if you do so, you will probably need for most of this alteration, and in order to have 100% of them, to look at the RNA level. We know that for exon 14 skipping mutation, if you look at DNA, you might miss 40% of them, 40, which is a lot. And last but not least, what we start to learn is about heterogeneity, even in the primary tumor, a fortiori at resistance, where I'm quite sure in the future we will understand better how heterogeneity is meant by single cell profiling. Melanoma colleagues have started to do that, and we need to be able to move in the future also using these very complex technologies, maybe not on the routine basis, but we need to understand how some selection and outcome differences could be perceived across patients. And of course, the modern, and it was a topic of ASCO meeting, right, was tissue versus liquid. So we know now that everything can be done in the liquid in terms of molecular alteration. So if you think about tissue, of course, tissue is needed for pathology information, histological subtypes, PD-L1 assessment at the time being, and of course also assessment of DNA if you need, also of RNA. Liquid biopsy is less invasive, allows for a better turnaround time, reason why many US centers do both in parallel. You can capture heterogeneity, but the problem is today, you can still not look at PD-L1, you can still not look at histological subtype, and you can still not assess RNA, and we are far from being able to do that. So I think we have both technologies. In Europe, we'll have to choose. We can't do both. We need to choose one only for reimbursement purpose. I know in the US, they are more lucky, but I have been speaking in ASCO with some colleagues who are leading now the initiative of doing only liquid, which is kind of a revolution for me, a topic for discussion, right? This is a slide from Natasha Lay from Canada, who has sometimes this very pragmatic reflection about things a bit European type, where of course she was still thinking about the complementary approach, meaning that she is still looking at tumor tissue first, and considering here in this way to move to use liquid biopsy, liquid sequencing at resistance, or when tissue sample is not available for genotyping. So a kind of by default or at resistance sampling, which remains my way to move. It remains the way to move of many centers. I could look in a survey, but it would be interesting to know what you do. Of course, when we speak about resistance or rebiopsy, you know why liquid biopsy should be better to cover heterogeneity, but also because we are still unsure that it's always needed to rebiopsy. So it is also a way to minimize the complications we might induce by doing it without certainty about the importance. And of course, allowing for a better time frame and turnaround time if needed. So that's something we consider here. Last but not least, and unfortunately, you probably have heard that the MYSTIC program, the MERMAID program, I was the leader of MERMAID 1, I was in the steering committee of MERMAID 2, has been stopped because we all think that minimal residual disease, meaning detecting circulating DNA after a radical treatment, might be a way to understand if a patient has a risk of relapse, and maybe even adapting subsequent strategy, how long, how much, and what. But at the time being, as I said, MERMAID had to stop because of feasibility. MRD is very difficult to assess. You need a private signature, you need a high level of sensitivity, and you have a very low ceiling for that. But there are some data showing that basically MRD presence or absence defines a different level of risk of relapse. Unfortunately, and it is a very nice trial which look at adjuvant chemotherapy of Xia and colleagues. You also have the Frisone data, and recently the IAM Power 10 data for immunotherapy. However, what we learned from this trial is two things. First of all, it is more prognostic and predictive, meaning that your adjuvant strategy is still valid even if you are MRD positive or MRD negative. And what I would like you to pay attention to is even in MRD negatives, there's a pretty high level of relapse, meaning that we are still not sensitive enough with MRD to really qualify the ones who will not be at risk of relapse. So interesting, prognostic, not predictive, and not sensitive enough. but I'm sure it's going to be for tomorrow. At the time being, we like to use ctDNA, sometimes in advanced disease, in order to understand the risk of progression at any time of the treatment. Also, maybe to try to understand what therapy to give. So ctDNA might serve the stage 4 disease beyond minimal residual disease in order to understand if potentially the patient will do well in the next steps. Usually it reads positive 9 to 12 weeks before a CT scan. So it's a way to follow our patients. Of course, policy speaking, there are challenges in precision medicine. And of course, we start for all we have been building around the EGFR, the assay validation, the clinical qualification, and the transfer to broad population. The paradigm is really EGFR. But at every step of this building, remember that you have bottlenecks. So of course, we spoke about sample acquisition. I found this slide of major importance, right? Sample acquisition is a problem and it's not trivial, on the contrary of what you think. The choice of the NGS assay is not trivial because of course of analytical validation, think about RNA, but also of costs and availability. I will look at it later on, also the scalability. Of course, you need bioinformatics to read, depending on what you need, also about the allele frequency, and it has to be standardized. You need a fair and prioritized reporting system, looking at the clinical relevance of what you report. You need a tumor board to understand also the scalability outside of our institution, outside of academia. And of course, you need to have a portfolio of matched drugs in order to change the paradigm of treatment outcome. So these bottlenecks are defining the whole advances revolution, but also the difficulties we have. In terms of scalability, we have been developing this SCAT, is a scale for actionability of targets within ESMO. It's Joaquin Mateo, who has been writing it with the group of molecular precision oncology. And as you can see, the idea is to qualify everything we do according to the level of actionability. Of course, EGFR would have an evidence tier 1, but when you speak about PIK3CA, you will probably be at an evidence tier 5, meaning that there are some things if you have to prioritize in your health system that maybe you should not do because you will not have the resources to do everything. So the scale is very important for us, but also for the pharma industry in order to understand how we consider the targets. This being said, that is what we now measure, the molecular testing across guidelines. So as you can see, higher up has a high likelihood of being included in the algorithm. Down and top this slide, it's the article of KISS-CARE. It's a lower probability of being assessed. And as you can see, the KRAS, MET, RET, and HER2 are now part of the, I would say, recommended expanded panel testing, but recommended, not mandatory in NCCN, ASCO, ISLC guidelines, meaning that still we probably live in an environment where many patients are only doing the blue ones on that slide and qualified for the blue ones. And of course, there's a whole range down the slide of other potential biomarkers, tier 4 or 5, according to the SCAT, that we are all struggling with. But it's quite nice to see the slides of 2022 advances, looking at these targets, where you can see for each of these strategies, the small letters showing you what has been approved. You will have the slides, of course, in 2022 in all of these targets. So you look at the red, for example, in the C, you had selpercatinib by FDA in frontline, second-line EMA, pralsetinib, FDA and EMA frontline. So everything is really giving rise to opportunity for a better journey for our patients. And this is quite amazing in 2 years to see this list of drugs through the both regulatory bodies being recognized. Of course, I told you about the emerging biomarkers, what to think about them, PIK3CA and RG1, we have heard about it, of course, the HER2, with some bottlenecks, some failures that you can see on these slides, some toxicity, for example, for the PI3 kinase. So really a very variable amount of benefit. And keep in mind this wonderful paper from Jean-Yves Blais and colleague, who were going beyond the guidelines that I have shown you here. You go beyond that and you consider in a molecular tumor board the rare targets. And this being done, an exercise of guessing what, an exercise of trying to make the best use of what we know. You can see that through the molecular tumor board in the profiler study beyond the standards of care, you could see that 6% of the patients who were characterized basically received matched therapy to an alteration, but of course with a very low tier in the actionability SCAT scale. So 6% of these patients received an experimental matched therapy with an overall response rate of 0.9%. So is it priority? I'm not so sure. And the conclusion of Jean-Yves and colleague was to say molecular screening should not be used at present to guide decision-making in routine clinical practice outside of clinical trials. And it's very important to me. Of course, last but not least, we start to learn that a mutation is not everything, because we have this co-occurring landscape of genomic alteration that have emerged as core determinants of the molecular and clinical heterogeneity, particularly in lung cancer today. This oncogenic driver mutation can have a clonal or a subclonal other components. Think about this one, for example, where you already have for some of the mutations some overlap with clonal dual mutation, KRAS, EGFR, MET exon 14, but think also about this difficulty, for example, of looking at P53, RB1, P10, MET amplification, de novo acquired. So all these co-occurring mutations give rise to some maybe prognostic, maybe predictive subgroups of patients that will have to be characterized in the future for a better targeted treatment. So beyond what we have been showing, we still have to learn all of this paradigm about the implication in resistance to therapy, the paradigm of co-occurring mutations, which will be important to help our treatment decision. So this is the two sides of politics. The last one is confidential. Please don't share it. This is the one which is not. It is about the LUCE. LUCE is a lung cancer group, advocacy group in Europe, who surveyed many countries to know who are the countries in which molecular testing in November 2019 was available, reimbursed, not reimbursed. So as you could see in many European countries and for several alterations, the reimbursement was simply not in place. Think about BRAF and KRAS, which now have lots of drugs, even about ROS1, PD-L1 and ALK. Some of the countries in Europe in this environment, which is considered as being accessible to innovation, it was not available. And this survey, we are redoing it in collaboration with Gustave Roussy in ESMO, in Europe and beyond, trying to understand the accessibility to NGS testing and also the reimbursement of NGS testing in Europe to start, and then beyond globally. And the last slide is where we are today. It's confidential. It will be submitted, presented at ESMO this year, but just to give you a glimpse into this amazing situation. So it's about here, the left-hand side, you can see, do you believe that there is equitable access to molecular biology tests in your country? And the national societies, as well as lots of key opinion leaders and ESMO members, were answering this question. So as you can see, unfortunately, there's a lot of no. And when you have a two arbitrate, it means that some said yes, some said no. So can you see how this picture is dramatically showing you that most of the colleagues think that there is no equitable access to a fair journey, right, to molecular biology tests in their country, in Europe. So this was, to me, absolutely impressive. And on the right-hand side, this is the accessibility to small panels, less than 50 genes across European country. Yellow is always, orange is usually, up to the red, which is never. And as you can see, the picture which I would have expected in lung cancer at least to be yellow in most of the European countries, always access to less than 50 gene panel. Look at the first column, is far from being yellow, right? It's even pretty orange, which means occasionally. And we have also all these slides that we'll present, of course, about who pays for that, private insurance, the patient out of pocket, or the public insurance. But this is just about accessibility. So imagine how poor we are today in making this, I would say, journey into cancer and personalized oncology, making it equitable and fairly distributed. So this was my last political slide, and I guess, and I hope it serves the introduction of the meeting, and it's really a great pleasure for me today to be able to open this wonderful meeting, and I promise I will be here next year. So thanks a lot.